Okay, so this is a patient that we are going to take care of. So you're the admitting resident on cardiology, and you get a call from the ER. You have a new admission. The ER sign out is that this is a patient with a recent 2-vessel CABG performed at Rose Hospital, who's being admitted for shortness of breath and volume overload. So you got that call, so you already know what to expect in terms of his volume status when you're down there. How do you all think about volume overload? Maybe we can start with one of the interns. Do you have a method to your madness when a patient comes in with this complaint?
Look out for ABV, crackles, edema.
Perfect. So definitely some of the things that we can see in physical exam. How do you begin to form your differential? Before you even get down there, the ER is like, this person is grossly volume overloaded. What are the things that you're thinking about or that you're worrying about?
Thinking about heart failure.
Perfect. So heart failure, is that the issue? Kidney failure? What other things do you worry about? Liver. Okay. We're hitting all the main organs. Anybody think of anything else when it comes to volume overload? Iatrogenic, so maybe he's getting fluid at Rose from his surgery built up.
Protein losing and
Love it. So some GI things. Okay, let's scoot over to the side here. And for us to sort of talk through together, when we think about edema, we're really thinking about what's happening. Oh, sorry, this is jumping around. At the level of our arteries, veins, and lymphatics. So, what are the issues that can happen with someone's veins? Let's start off there. That could cause volume overload or swelling in that area. Yeah, perfect, a blockage. And so usually that will happen with things like, love it. So some sort of venous obstruction. So DVT is definitely one of them. What's something else that can happen that can cause venous obstruction? Chronic stasis. And then what organ failure can contribute to venous obstruction? The liver. So if your liver is very fibrotic, blood can't pass that portal system. So we think about venous obstruction, we think about liver issues. Okay, moving on to our capillaries. What are things that can happen there that can cause volume overload or edema? What's the mechanism by which heart failure causes volume overload?
Increased hydrostatic pressure.
Yep, so you have increased hydrostatic pressure. That's due to a retention of perfect, sodium. So you can have increased sodium retention. Or we can have our increased hydrostatic pressure. What else is a component of pressure in blood vessels? We have hydrostatic pressure, and what else? Great. And then what are problems with our oncotic pressure that can lead to volume overload?
Low oncotic increase.
Yes, low oncotic pressure. How does that happen? Louder, I couldn't hear you.
Malnutrition.
Malnutrition, great.
Decreased production of proteins.
Yep. Okay. And then someone mentioned some other things. Yeah, low albumin, like protein losing enteropathies. Okay. And what about our lymphatics? Great, obstruction that can be from And then procedural things too, right? Somebody has a lymph node biopsy that messes up their lymphatic drainage. Okay, great. So great review of why edema happens. We can zoom out. Ugh. Okay, well, let's go back to our patient. So you guys have all of this in the back of your mind as you're going downstairs to the ER. You're thinking about different problems with the heart, the liver, the kidneys. You hit the nail on the top of the head. So what are you going to do when you're down there in terms of your history and physical? What sorts of things are you going to target? Do you want to just jump right into the HPI that we got? Okay, let's do it. So we have a patient here. He has a complicated past medical history. Oh, this thing is not zooming out. Let me change one thing. Okay. All right, is that big enough for you guys to read? So he's a 56-year-old male. He has a complicated past medical history. He's coming in with shortness of breath and swelling. He had a CABG about 1 month ago at Rose. Since then, he has felt increased swelling in his legs all the way up to his head. He doesn't have the same chest pain that happened to Rose, just expected post-CABG musculoskeletal pain. No palpitations, no infectious symptoms. He says he has to prop himself up at night to be able to sleep. He also has some worsening fatigue. And then he notices some kind of edema in his scrotum if he stands for too long when he's doing chores around his house. Any thoughts about that?
I think we're in kind of the path that is getting at like local versus systemic causes.
Mhm.
And it definitely seems more like a systemic. So we're going to take steps to get stuff off the table.
Perfect.
More like liver, kidney, heart.
Okay. Great. Any questions about his HPI? All right. So let's get our next piece of data. So who thinks it was helpful just to have a line that says complicated past medical history? Not very useful, right? Maybe this resident was a little bit lazy or tired when she was admitting this patient. So let's look at his review of systems. It's positive for activity change. He's feeling really tired. Just had a CABG though, so maybe not really unexpected. Some fatigue, some weight change. He's gaining weight. Facial swelling, some shortness of breath. He has his chest pain from his incision and his surgery. Then some leg swelling, and then abdominal distension and abdominal pain. Any concerns or questions for that? And then anything that you would have asked about specifically to help you work up the etiology of his volume overload that's not specifically mentioned here. No? Okay. Well, let's get his past medical history so that way we can talk through it. So it's not just complicated like this resident said. He has a history of CAD. He's had a 2-vessel CABG that was done at Rose. Also has a history of hypertension and hyperlipidemia. He's had a renal transplant for ESRD secondary to hypertension diabetes. He's a type 1 diabetic. He also has HIV that's well controlled, hepatitis C, which he's had treated with Harvoni, and then a history of depression. So in looking at that list, do you have a clear slam dunk of what the cause is of his volume overload? Okay. What organ systems could be affected? Heart, kidney, liver, basically everything, right? So what are we going to do to figure it out? Let's get his physical exam up, and then you guys are going to break up into groups and talk through your initial studies that you want. So we'll do his medications as well. Nothing surprising there. He's done a bunch of cardiac meds given his CABG and his CAD. For his immunosuppression, he's on tacrolimus, mycophenolate, and prednisone. He has an insulin pump that he's been using without any issue for the past couple of years, and then his HIV meds. Anything concerning there?
When was his kidney transplant? Before it happened?
Yes, he's had a post kidney transplant for like 10 years now,
Okay.
and then cabbage was 1 month ago.
And when did the swelling start?
It started about a couple of weeks ago,
Right after cabbage?
like a week or 2 after.
Has he been on the prednisone for a long time?
He has. That's just been part of his immunosuppression regimen. Other questions about his meds?
Is she taking all of it?
He is. Okay. We have a social history. So he says that he uses marijuana gummies occasionally. He quit smoking when he had his cabbage done, so that's a pretty scary event for him. He has a 44-factor history. He uses rare alcohol. He doesn't use any other drugs presently, but has tried things like heroin in the past once, and he works at the airport in customer support, but it wasn't working due to his cabbage. Has a roommate who helps him around the house, but otherwise is pretty functional in his ADLs and non-ADLs. The last thing that I'll give you is his physical exam. Okay. So, who wants to take me through his physical exam and their thought process around what it could reveal with regards to his volume overload? Is his exam normal?
His exam was abnormal. His rose of hypertension, 204/89. His heart rate was on normal limits. He didn't have a fever. His normal respiratory rate saturated well on I'm going to do oxygen.
Mm-hmm. Room air.
Going through cardiovascular, his rate is regular. Rate rhythm are regular, and currently no murmurs. Rose, look else. 2+ peripheral edema, and overload. Because he has a GVT up to 45 degrees. He's well confused. His lungs are not affected by his edema because he's really comfortable. And lungs are clear except for decreased breath sounds in the right lower face. Which does not sound like volume overload in the lungs. It sounds maybe he does something extra.
Okay, so what would you expect to hear if he had gross pulmonary edema? That's your question. Yes, love it. All right, anything else that you would have done on your exam or other things that you would look for? What was that? Okay, hepatojugular reflex. You upper levels, would you do anything else for your exam for this patient?
Probably like a fluid wave or even have like a look for a thing.
Great, so grabbing the ultrasound, taking a look. Okay, so now that you guys have all of the objective information thus far, I want you to pair out your tables and talk about what would be the 2 labs that you would get and then the 1 additional test that you would get, and we'll walk through some of that information. I'll give you guys about 2 minutes to talk through that. All right, guys, let's start to come back together. Heard a lot of good discussion on the tests that you guys were thinking about. Jessica, does your group want to start? What are the 2 labs that you guys want?
We were thinking of CMP, we also look at liver function and sodium levels, and then a
ENP? Yeah, okay. So here are the things that we want. CMP, ENP. Other groups? What did you ask for labs? Go to this table back here. Same? Okay. We want seniors, anything else? The US. Okay. All right, table number 1.
We have CMP and BNC.
Okay, so 2 more counts for that. Okay, and then starting with you guys, what's the 1 test that you would want? An echo, okay. Table 2, what would be your test that you want to order? Echo, we talked about it right after quadrant. Okay. TTE, right after quadrant.
Echo.
Echo. Everybody wants the echo.
Well, I want the transplant ultrasound.
Transplant
I'm just gonna
ultrasound?
put all my eggs in the renal basket.
Okay.
So that's like the most worthy thing.
Okay, so, pretty good consensus here. Nobody wants to get maybe a chest x-ray?
We said a chest x-ray, we assumed it would have been done.
I can go downstairs right now and just.
Let's start you guys off with some of your findings then. Let us start first with this chest x-ray. So, remember he is 1 month post-cabbage. Get that aligned for you guys in the middle. So take a minute with your teams and talk through what the abnormalities are. And then I'm gonna have someone come up and draw the x-ray to point out what that's called. Any volunteers to do that? This iPad thing is really fun. I'm gonna tell you guys. Okay, take 30 seconds and then talk about the abnormalities with your group.
That's weird.
All right, let's go back together. Kira is going to walk us through the abnormalities that she and her team have seen. Okay, so go ahead and just draw right onto the x-ray. What's abnormal?
Not gonna be very exciting, but the abnormality that we pointed out is scary.
What's going on there?
We have some debate about how much of that is an effusion. There's one thing which happens running ankle and then effusion versus elevation of the right knee diaphragm.
Great. Anything else you guys noticed with the x-ray? Yep, so this is a perfectly clear phosphorenic angle either. What else?
It also looks like, here,
Okay.
this is just something else.
Yeah.
Is this the fissure right here?
That is, so we see a line there. What does that mean?
Fluid.
Yes, fluid in the fissure. Okay, so this man has pretty large right-sided portal effusion, a small left-sided effusion. You can see fluid going all the way up into his fissure. That has his sternotomy wires there in his chest. Don't miss those. But anything else big that you guys thought about or saw?
part where it does look kind of weird.
It does,
It's almost square.
yeah, it's a little funky.
Is that like a pericarditis, like a water level sign? I don't know. Or is that just nothing?
I think, we probably bypass that, and you just have cardiac surgery a month ago, so we won't put too much stuff into that. All right, so we got our x-ray. Let's scroll down. The ER is gonna be good colleagues for us, and they also got this guy. I have a volunteer to point out anything that's normal or abnormal about this EKG. He has no chest pain, he's just tender over his sternotomy site. Did our progression? No.
It is a little crappy.
Maybe some forward progression, but otherwise, what would you say? Normal, great. So overall, normal sinus rhythm, maybe a little bit of 4-hour wave progression. Okay, and then people had asked for some labs, so let's get started on those.
I would say the QT is also kind of borderline.
It was a little long, yeah. Okay. What do you guys want first, your CMP? So here is a TMP and a CDC. I put his prior values in the computer in parentheses. And then I think some folks had also asked for LFTs, so you can get those in as well. Give you guys a minute to go through them, and then maybe someone can walk through what's catching their eye.
And then I don't know which is which virus, but AST on the left, ALT on the right, and then alpha. I mean, not wrong, and maybe it's better. But next to my BMP, I put like a little, and I have Cal's math.
So, walking through his ECG, largely there, just giving any information about why Mr. Line is below the top. All right, guys, we're gonna talk through his labs together. Carl's gonna walk us through his thoughts about his EMP and CDC.
Yeah, so obviously the most, to me, I noticed that he does have the strap in his hemoglobin. That's in the absence of like a clinical history reading and just had major surgery, right?
Yeah.
So that's like the most impressive number jump. I'm gonna sort of put that on the back burner and consider the AKI
Great.
of 1.62. Of course, that doesn't tell us why he has an AKI, right? As far as their differential of like primary renal issue versus cardiac issue, it could certainly be either. The hemoglobin drop does make me maybe favor a renal issue a little bit more, because the kidney mixed echo. But
What about his LFTs?
the hyper K, yeah. So I actually would. To me, they're surprisingly normal if it's sort of like a right-sided heart failure. You expect at least a little bit of a bump, and then he has KDOT or like a congestive hepatopathy. So I think putting it all together, this sways me a little bit more towards this is a graft issue, this is a renal issue. But doesn't make the diagnosis, we need more information.
Perfect. Anybody have any questions about how Carl walked through that?
Can I say something real quick?
Yeah, go ahead, Dr.
So congestive hepatopathy actually has a pretty interesting LFT pattern. You'll actually often see a isolated rise in the total bilirubin with the rest of the transaminases being normal. That's kind of the classic congestive hepatopathy LFT pattern, which we don't see here.
Yeah, dropping some knowledge. Okay, so you're putting in your admission orders, people want that UA, he can't pee yet, so you're gonna grab the butterfly, you're gonna do your bedside echo, because you're worried about this guy, he has major cardiac surgery, right? You don't have a prior for comparison, because it was done at Rose, so we don't have access to the Meditech system overnight. But,
A quick question, sorry, before I move on.
Yeah.
So his bundle gravity ratio was over 20. Is that like a good number to like follow, or is that more like anecdotal? Like I never really know how to feel about those. If I should be like, yes, it's pre-renal, or like it's not.
good question, anybody have any thoughts, or have what they handle UN to creatinine ratio in AKI?
It is a good question. You do learn classically, it's like greater than 21 is pre-renal, which of course means like, is this volume depletion or is it cardiorenal? Pre-renal is at the end, but it's kind of one of those things that like can be suggestive or it can be a guide, but isn't like diagnostically helpful. And
That
it's
was a
like,
question.
yeah,
Good to know.
no, totally. But good question.
And then, a bunch of other things that can affect the UN to creatinine ratio as well, if they're having a GI bleed, other things going on, so, it's pretty non-specific, you want to walk through your clinical history and the labs that you have. Great.
You'll see at this institution, people trend to follow phenas, slightly more ureas, and the same is true there, where there's actually like not that great of evidence behind those, and so using your clinical story tends to be much more important, but you'll see phenas used here somewhat more.
Phenas are, I feel, misleading as often as they're helpful.
Yeah, I ask my interns not to get
Actively
them.
misleading.
Well, especially in some of the volume order, because like Carl said, if Nina's less than 1, it's the same, it's, you don't, that doesn't answer your question at all. If it's, you're dehydrated or if you have too much fluid. All it does is communicate.
Okay. So you grabbed your ultrasound, you're going up to see the patient because he's getting admitted to cardiology, right? So we have to make sure that pump is working. Does anybody know what view we're looking at with the ultrasound with this shot? Perfect, parasternal long access. And then do you guys know how the probe is positioned to see this? Gonna ask you to
Parrot
draw
to the straight.
where the probe would be.
Along
Yeah.
the long
You
axis.
guys are looking at the body over there with the walk through. Second word is towards your right shoulder. Yeah. Here. Perfect. So that's the angle of the probe as you're doing this ultrasound. Questions on that? Okay. I'll play this. I'll let it loop a couple times. That way you guys can get a good look, and then we'll walk through the anatomy that we're seeing in this video. So go ahead and take a couple minutes to watch. It was a little jumpy, I apologize. This VA Wi-Fi amps, high quality. Okay, I'm gonna pause it and let's talk through. Get a little better shot than that. Okay, who wants to take a stab at telling me where your left ventricle is? Ben, Anya, on you?
Yeah, it's like upper left.
Perfect. This guy right here. That works there. Yeah. And then where's left atrium? Great. The right ventricle? All the way to the top. You're just finding it out. Left atrium's kind of hard to see in this shot. What's this right here? Perfect. Outflow tract, and there's your valve. Okay, so in looking at that video, what would you guys say about his pump function? Is it low, high, low, normal? Yeah, and then how do you know that it's pretty good? What are the things that maybe upper levels look at when you're looking at this ultrasound?
Like the EPSS, or the endpoint septal separation.
Perfect. Do you want to point it out every the video again?
Yeah.
Yeah, I'm gonna erase all these markings. Play the video again, and I'll pass you. Yes, you can just go ahead and draw right on it.
So you're looking kind of the distance between the mitral valve here, as it kind of how close it gets to the septum. I forget the exact values, but this looks like it's almost touching. So.
We're getting good squeeze. The other thing that you guys can look at is at the actual walls of the ventricle. And so our borders are coming very close. They're almost touching up here. And so we know that the two sides of the heart are coming together. So if you were eyeballing it, you know, you could say that it looks like it's a pretty normal EF. Questions on that?
You could actually say it's a little hyperdynamic, because usually if you think about like what a normal ejection fraction of the heart, it's like not like ejecting basically all the volume that's in the left ventricle. So if you see those walls, you got a good view and they're coming together, heart may be a little bit hyperdynamic.
Okay, questions on the echo? Yes, no fluid around the heart, so you know the heart's looking okay in terms of an effusion. Okay.
So there's no explanation for the chest X-ray.
Yeah, we still don't have an explanation for why he has that, but we'll get to that. Okay, and then some people have wanted some other studies. We'll give you an ER, drug stroke and DMD. Anything alarming there? WMD high, low, high. Hard to say in relation to other values. It was first one in the system, so we hadn't had others to compare it to. Trope is negative, which we expect because he's not having any chest pain. But he gets admitted. You guys put in your orders. He gets some Lasix, and then in response to that, we get this for our UA. Carl, I think you wanted UA.
Yes.
Want to walk us through how you would interpret it?
So in a word, this is badness, especially in some of the transplant. We got protein in RBCs, which is potentially consistent with like active urine sediment.
Yes.
Active urine sediment is potentially like intrinsic renal disease, bad news, of which rejection is on the liver.
Okay. And then what are we going to do once we get this spot in urine? Can we just say, oh, he has a lot of protein? Call it a day? No. So you get this result back overnight. You know, it's 3 a.m. now. You're getting ready to wrap up and pass this patient off in a couple hours. What's the next order that you're going to put in? Yes. Here, all good things. So you want to collect a 24-hour urine. So we should hopefully take that order in. 24-hour. Urine protein to creatinine. So that's cooking. What else are you guys going to do to help work up this patient for now?
I mean, if rejection is a differential, eventually he'll have to have a biopsy to confirm his rejection.
Eventually biopsy. Great.
I don't know what.
And I think a couple people had asked for a few other things like a renal ultrasound, or right upper quadrant ultrasound. So let's give you guys those. So he gets an abdominal ultrasound overnight, and this is your impression. So mild hepatomegaly, mildly increased parenchymal echogenicity, horizontal texture, you see in the setting of hepatocellular disease. No definite evidence of cirrhosis. They call this right pleural effusion that we saw on our X-ray, and then atrophic venous kidneys. He also got a renal ultrasound overnight. So we don't have that here in the abdominal ultrasound, but let's take a peek at that. Okay. So his renal transplant ultrasound shows pink vasculature, appropriate direction of flow, elevated renal resistant indices, new heterogeneous renal transplant parenchyma, and then findings are non-specific, cover bunch with projection or edema, no hydro. Thoughts about these two imaging studies that you were able to get overnight? Raising suspicion for some diagnoses, lowering suspicion for others.
The liver echo confirms the diagnosis. He's for overeating, there's no liver problem. Kidney echo suggests what the VA only showed, which is
Yeah, so maybe less likely to be a primary issue with his liver. You know, he did have some liver dysfunction, and a history of Hep C, but doesn't look like he progressed frank cirrhosis as the cause. Look at his heart on his echo, and that also looks good. And so now looking left is the kidney.
This makes me also think like hypertensive emergency with like renal like damage with the IVs on ultrasound.
Yeah, so his blood pressure was pretty high when he came in, so is that a possible outcome of hypertensive emergency? Great. Let me give you guys another question. So I don't want to forget about his chest x-ray. So he has this big effusion. What do we do when someone comes in with a new effusion? Yeah, so do thoracentesis to figure out why. What are other reasons why someone might get thoracentesis? So they have new fluid. What other indications for doing a flora? Therapeutic. And what's the therapy that we're giving? Why would you do it?
Moving fluid in the lungs so it can expand.
Yeah.
Not cautious.
Perfect. So if someone's really short of breath and they're hypoxic with a big pleural effusion, you can drain it. He's not hypoxic. He was short of breath though. And then what's the last thing that we use our thoracentesis for? What if he came in at a temperature of 102, he got a cough before? To rule out.
Source control.
Yeah, so source control, if you had a pharyngeal effusion or empedema, we have to tap the fluid to make sure that we get to the root cause. So with your groups, talk through what are the studies that you would order on this pleural fluid, and then how do you define the different types of pleural effusions that we can diagnose with that fluid. Take about 2 minutes to talk with your groups, and we'll walk through together and improve the diagnostic criteria for that.
Or like radio teachers. Yeah,
But actually,
doesn't
doesn't
that
that
Yeah, that's all.
Yeah. Other one.
Okay, so let's chat. What are some of the tests that you're going to order to work up this man's pleural effusion after you do your flora? Shout them out. What labs are going to order to work up this patient's pleural effusion?
Serum LDH.
Okay, serum LDH. What else? Protein. Serum and fluid. Love it. What's that used for? Great. So just so you guys don't have to memorize Light's criteria. So you need your pleural protein, your serum protein. You need your pleural and serum LDH. And then our third criteria has to do with the upper limits of normal. Can I have someone talk me through how they define the different types of effusions? So So we're gonna use Light's criteria. It could be a blank or blank. Okay. Or transitive. What's the difference between the two? Or when does each one happen? What conditions?
Transudated will happen with volume overload because it's just the serum of the blood getting squeezed out with the increased hypoxic pressure.
Perfect.
So it will be very thin, low LDH, low protein, usually bilateral. Exudated like there's a lot of causes.
Yeah, right. So I'm gonna talk through that perfectly. The way that I think about transudates is that you have your fluid and it's just transporting itself across membranes where it shouldn't be. And so things like heart failure, nephrotic syndrome, other things like that can cause transudates. For exudates, I think about a process that is flowing slow. So that's when your things like malignancy, pancreatitis, amyloid, all of that comes into play, and also infection and other autoimmune causes. The other thing that you might hear about are paranemonic effusions. Who has a patient or has had a patient in the past with paranemonic effusion? Do you guys have a good grasp on what defines complicated versus a simple paranemonic effusion? Glucose and pH, great. So let's talk about simples. What defines a simple paranemonic effusion?
Means when the glucose be in the normal range, not low.
Yeah, not low, greater than 16. So that means by default, what's have to be complicated? Great. And then pH?
pH would be low, complicated, and higher.
Okay, so we're at 7.2, so pH would be less than 7.2 for a complicated, greater for a simple. And then LDH is another criteria that you can use. You guys have a number in your head, separate those two. What's 1,000? If it is less than 1,000 or greater than 1,000. And then for both of these, you have to look at your gram stain as well. So complicated will have what? Positive gram stain. It's possible, sometimes you have to see the actual organism, but if you fill the other criteria, then you should talk about putting it next to help drain that. And then where does NPEG go into the mix?
It's like complicated, it's like loculated. Very bad.
Yeah, so the definition that we use is frank pus on visualization of the fluid, but it's definitely a complicated paradigmatic. So we're gonna put up this guy's studies, and then I want you to take 30 seconds, use whatever tools you need to, and then tell me if he has a transudate, exudate. Try to put Light's criteria up there for you too. And then whoever gets it first, you need to shout out where he falls. See. Okay, anybody have an entry yet? Perfect, transudative. So I know it's something else going on, not some sort of infection, not an autoimmune thing necessarily. Okay, you guys are working hard on cardiology, getting all those done and prepped for the daytime team. Carl over here is still wondering where are my urine studies that I asked for when this man first came in. So let's give you guys some additional studies. So that is his stopped urine creatinine protein that we did overnight. And then because you guys are excellent residents, you also got to order things like tacrolimus C3C4. If you remember from his HEB, his tacrolimus goal was between 5 to 7, I believe. And then let's also drop in after 24 hours. Oh, sorry, that actually is his gram stain. We can delete that from his infusion. There's nothing seen in his gram stain. Okay. Here we go. This is his 24-hour.
Oh, wow. That's like really discordant with this now.
It is. So what does his spot come out to be? Do you guys have to calculate that?
Wait, no, it's not, sorry. I was off by 5%. Yeah, it's a lot on both.
It is. So, what does this range sufficient for this particular patient? Nephrotic syndrome. Who has a good definition of nephrotic syndrome?
Is it 3.5?
Yep, so urine output or urine protein are 3.5 grams per day, and the patient has to have signs of peripheral edema. So this guy had edema in his legs, and also I mentioned that his scrotum would become edematous if he stood up for a long time. There was one thing out of his history that could have pointed you into this direction early on. Do you guys pick up on anything that he mentioned? Do you want to see his HPI again? Yeah, so Claire is saying he had swelling up to his head. And so he was likely having periorbital edema at home. And it's just another plug for you guys to listen to your patients. I was on cardiology admitting this guy, and he was like, I'm swollen up to my head. And I was like, it's not like his heart, but still, you gotta go to cardiology. So don't forget your other organ systems in this process when you're on tablets. So as you guys appropriately deduced, he has nephrotic syndrome. What are we going to do to work up his nephrotic syndrome? Someone had mentioned it previously. We need a biopsy, right? So you get his blood pressure under control. You call renal, and you're saying, I'm worried about nephrotic syndrome in this patient because his urine protein creatinine is above 8, and he's coming of peripheral edema. And so after a couple days of blood pressure control, the one goes down for his renal biopsy, and this is what we see. So I will make it bigger on the first one. So that is just the transplant kidney. Let you guys take a good look at it, and then we'll sort of walk through the other histology findings. What are these things here? Yeah, perfect. And then what's this thing here? Thick wall structure. Artery. Okay, so let's walk through it. So when pathology is looking at the slides, they look for capillaritis, or basically inflammation of the capillaries. And so you can see that we have all of these blue cells where they should be. Those are all lymphocytes coming in, markers of inflammation. If we push over, we can also see that his glomeruli was a little bit too thick in terms of the lining of the folds. And so that's also glomerulitis. And then you can see here around his blood vessels, there's thickening of the blood vessel walls. So that shows highly arteriosclerosis. And then lastly, on these special stains, we can see here that he's got the double contours on his membranes, which is also discerning for some sort of inflammatory process in his transplanted kidney. And this gentleman ultimately ended up having chronic antibody rejection of his transplanted kidney, causing his volume overload. Treatment? Any thoughts about that?
Steroids.
Steroids, great. Other options? It's okay. Coma.
Some of these people get like final blood.
Yep, so they can be like reintroduced into their kidney suppression.
If his kidney, transplanted kidney has nicely really failed, we cannot get his liquid off his breast.
If his what? His kidney transplant has failed?
Yeah, we have to dialyze it a little bit.
We would have to dialyze him, but he responded to furosemide. So he was able to still produce urine. It's always a good question though to figure out, is my transplanted kidney still viable? So for him, he ended up on a steroid burst. You can also think about things like IVIG or rituximab. If someone has active antibody-mediated rejection, so they get the surgery, their transplants in, they experience rejection right away, then we can use bortezomib and then also the tocilizumab as well. Obviously, you guys will be chatting with renal if it's coming to this with your patients. Questions on his outcome?
You use like also statins, like anticoagulations, what other products and stuff, or is it different?
So he was not on anticoagulation, but here he was on everything for his cardiac risk factors in terms of statins. So great question.
Can I ask you about, like, if I had this patient coming in, because clearly volume overloaded and had a Nephrotic fusion, I don't know that I would like jump to tapping him if I felt pretty confident it was a transient from his volume overload, but I feel like I've seen like attendings want to do different things in that situation.
Yeah, great question. So how do we order our management of these patients when they're coming in overnight? Also, I didn't tap him overnight when he came in. That was done a couple days later in his hospital course. But with the new adhesion, given his recent cardiac surgery and everything else, they want to make sure there was no other cause that was going on. So that's why he ended up getting it. And he was pretty symptomatic from it. So even though he was diagnosed for a couple of days, he still felt pretty short breath.
That makes sense.
Yeah. Okay, so today we reviewed a lot of things. We reviewed the pathophysiology of edema, why it happens, down to the structural level. We talked about the organ systems that are affected. We walked through initial workup for a patient coming in with volume overload. So things that you can check. Check their synthetic liver function with an INR and their albumin. Is it a history of cirrhosis? What do we know? If it's dark. We talked about doing bedside echo, your peripheral lung access, look at the pump function. And we talked about urine protein to creatinine ratios to see if they have nephrotic syndrome. We also reviewed Light's criteria for effusions, and then talked about definitions of complicated and simple paradigmatic effusions. And then we briefly touched on treatment for somebody with chronic antibody-mediated rejection. Any questions? Okay, so you guys looked at hundreds of volume overload patients in your career as an internal medicine physician. And this is my plug to not be fooled and always think it's the heart. There are plenty of other things, and this was a real patient who had all of these problems, clearly our organ system has been affected. So I think it's the perfect test case for a volume overload patient. Great. We'll have contacts tomorrow, and then Thursday, Dr. Andrews will be here.
No, I think when I get concerned, like the lumps where people are so profoundly volume overloaded that they're not making any urine at all anymore, or if there's left-sided heart failure, but in something like new onset ascites, for example, frequently those aren't involved, new onset renal problems.